Well, good evening and a very warm welcome to 7 Bedford Row, both to everybody that's here and also the people that are joining us remotely. I'm not quite sure where I'm supposed to be looking. There's a camera somewhere, but there we are. This is the 5th on the 2017 skeleton series. I'm so old and I've been here, or I was here so long, I remember the first one, which is years and years ago, but obviously they go from strength to strength. And tonight is no exception. Our first speaker, Dr. Michael Ingram, is going to talk, as you can see, about general practice, challenging and challenged. I'm not quite sure what that's going to be about, but it says here that his specialist clinical interest is in travel medicine. So probably you're thinking, you know, dodgy anti-malarials and really painful injections, but I've noticed that gin and tonic works awfully well. You get on a train, you get on a plane, the person comes along with a trolley, gin and tonic, that's the solution. Dr. Michael Ingram.
Thank you very much. I'll start by agreeing, of course, because quinine was put in tonic water precisely as a malarial treatment all those years ago, and so that's why, in fact, it had to be dissolved in alcohol to start with, and then they found a way of dissolving quinine in water, hence tonic water. So, as ever, you cut straight to the heart of the issue. Challenging. Well, I put this as I know it's a rather sort of vague title, but the fact is that general practice being in the state of crisis it is, I had to put the challenged bit as well. But let me touch on that. Let me just first of all introduce myself. I'm getting on a bit. I've been in general practice for 30 years, which is very useful sometimes when solicitors are looking for people who've been around back in the 80s and were practicing then in the old days of paper records and leeches and things like that. And I have to admit I was doing that. I've been an expert doing medico-legal stuff for about 27 years. I had a very interesting next-door neighbour who we got very friendly with, a chap called Stephen Irwin, who once looked over the fence and said to me, have you ever thought of doing some medico-legal stuff? And I said, what's that? And he explained it to me and I found it interesting, and he sparked off my interest in medico-legal expert work in general practice. I've had a political aspect to me, which is why there'll be a slight flavour to this talk, being involved in national politics and national medical politics and regulatory aspects of general practice in terms of the local medical committee, which is a statutory organisation which looks at general practice and on a national level through the General Practitioners Committee of the BMA. And I've also had the great fortune to have been involved with one of my partners in the practice in providing medical educational conferences, very much like 7 Bedford Row skeleton series. Our only difference is we tend to do those overseas and we charge our delegates for it, which might be a slight difference, but you know, you get what you pay for. And our conferences overseas, and we have run educational courses then, which is a great way of maintaining my educational expertise in organising these, attending them, chairing them, and of course learning from them. So that's a little bit about me, and I'm here really just to talk a little bit about general practice. And the aim of the talk, I think, is, first of all, I put here to understand the present state of general practice, just to get a feel of what it's all about. I also then want to move on to the challenges that you face, I think, uniquely amongst general practice, because, of course, general practice is virtually totally electronic. And you're working, forgive me for assuming these things, but I'm assuming you all work very much on still a paper-based system. The delivery man, the postman know that. It's things around. So how do you actually interact between the electronic methods we're using in general practice and the paper-based methods that are so common in medico-legal work? I'm going to then touch a little bit on the medical errors that occurs in general practice, sort of areas of vulnerability. And then I'm going to talk finally a little bit about tips on how to brief a GP expert and make people like me very happy. They always do. So there we go. That's what we're going to talk about. So let's just think about the nature of general practice. You've all, I'm sure, experienced that as a consumer. And yet the fact is that general practice is based on long-term care. It is remarkable how many people have a long history with their general practitioner. And as I said, I've been in general practice for 30 years, and I'm now dealing with my grandchildren. What that means is the babies that were born when I started have now had children of their own, and I'm dealing with them. And it's one of the great satisfactions of general practice is that longevity. And I still bump into people in many forms of life who said, I used to live around, I remember you were my GP and things like that. You think, yes, but memory's not that good, but it do that. So it is that affinity. And the nice thing is, rather like that advert, do you remember that advert for recruiting teachers? They used to say, you always remember that teacher. Well, perhaps not in the same way with your GP, but perhaps you always remember your GP as well. We do deal with a complexity of issues, which I'll come on to. We deal with nebula presentations. And often we're having to understand, and this is where the longevity of interest comes in, the interaction between the physical disease and the person who's experiencing the holistic approach. There's lots of pressures which I've illustrated there, but I'm sure they're not unique to general practice. So the fact is that in Britain we do have a very, very unusual situation. We are in general practice almost unique in having I say almost unique because you've got to cover the exceptions, haven't you? But someone will come out with somewhere. But we have this system of list-based care, and that means the whole population of the country is registered on defined lists with general practitioners. And that, as I said, is a unique situation. We have a total population coverage, and it's very interesting, if you look internationally, as the Commonwealth Fund has done, which is a US-based think tank akin to the King's Fund, it finds the level of health provision in the UK top in the world. One of the features, believe it or not, even I'm not sure it would apply now, but one of the features of that is access to healthcare and continuity of care. The whole population is covered by a GP, which of course isn't the case. That access and that intimacy GPs doesn't occur in many other countries. We work, as I'm sure you're familiar with, but many of my colleagues in hospital medicine may not be familiar with, we're an independent contractor. So you know that when you're looking at litigation, the fact is that we are independent contractors and not employees. And that our NHS contract rests with the practice to deliver all necessary care to our patients. It's what's called the John Wayne practice, which is John Wayne contract, which is a GP's got to do what a GP's got to do. And that's the way it's viewed. It's an open, it's not defined. And as I said, continuity of care is, in my opinion, an important aspect, which as a practice which values that continuity of care and is trying to work out how we can deliver it under modern workforce conditions and modern ways of general practice. We were very pleased to see an article in the BMJ, which came out earlier this month, which actually had that as a headline. That's the front cover of the BMJ, which said how seeing the same GP can reduce hospital admissions. And I think from your point of view as individual consumers, the frustration of seeing and having to go through the same thing with a different doctor each time, both on a personal and a professional level, you must see as a major problem. Personally, if you're a consumer of the health service, but also you see from the point of view of where errors occur, it is the fact that someone else is dealing with a problem again and again and again. I was speaking to a surgical colleague recently who was telling me, one of the great frustrations, he says, nowadays in the NHS, and I don't want to enroach on other fields, is the fact that I'll see a patient in clinic, agree they need an operation, but they won't come on my operating list. They might go on anybody's pooled operating list, which means that reciprocal thing means I'll go to operate on a patient that I haven't seen in clinic, that someone else has seen. I may not agree that it needs an operation. I may not agree it needs that operation. And of course, this lack of continuity is one of the major problems, I think, that faces aspects of medicine today, but it is a product of the way that the NHS is evolving. And again, the nature of general practice means that you're tending to manage a condition over more than one consultation. And I think one of the important aspects of general practice is, unlike the outpatient appointment where it's a one-hit situation, in general practice, you've got the opportunity to review, you've got the opportunity to actually understand how any set of symptoms evolve and to make sure that they follow a path that you would expect. And that's why the importance of dynamic review. What I mean by that is making sure that you're on top of things and not just reviewing in a passive way, but making sure that you are making sure that the patient's coming back for reassessment if you're uncertain. And that way you can use time as a diagnostic tool, because conditions are very rarely static. They tend to evolve. And you know that from your practice. I know that from my practice, and that's a different way of diagnosis. It's not something you can do easily as a hospital doctor and outpatients. So We're also the first port of call for all. And I've put two contrasting aspects of my work. One is that just the unsorted patient, people coming with a whole variety of different symptoms, fears, expectations, a whole set of things which you never have in textbooks. And it's very frightening when you actually start in general practice, because well, certainly in my time, you learnt in a sort of a fairly disease-based system, and what you encounter are a whole set of symptoms, none of which seem to make sense. And as you go through general practice, you're trying to make sense of these. And on the other hand, the other big stress is the multimorbidity, the complexity of modern patients. Victims of the success of medicine means that people nowadays are growing older and living longer with complex diseases all interacting, and I'll touch on that in a moment. But first of all, I'd like to come to the first rule of general practice, and this is the quote I would have on the Royal College of General Practitioners, and that is Voltaire who said it, and he said exactly that. Now, that doesn't apply to my colleague Mark Vanderpump when he's dealing with diabetes, I assure you. Because quite simply that doesn't work. But when you're dealing with many things in general practice, they're self-limiting, and what you're often dealing with are people's fears of disease, people's distress by the symptoms or things of that nature. But you've got to remember that very often nature will cure itself, and that's an important thing. First, do no harm, said Hippocrates, and that's important because interventions, inappropriate interventions, we've seen that with inappropriate antibiotic prescribing, as an example that springs to mind, is detrimental. So I think that's an important thing to remember. But whilst Voltaire's often right here, the key is you've got to, amongst this vast mass of symptoms that's coming in, general practice is the difficulty, the challenge, the stress, the essence, the ones that you stay your head above water and out of trouble, is being somehow able to sort out the wheat from the chaff. You've got to somehow find the various things that are hidden. I've put four presentations there that are so common in general practice, but sometimes can conceal really quite serious pathology. Back pain, tired all the time. If I had £1 for every tired all the time, my pension would be magnificent. But every so often, as Mark would say, it could be Addison's disease, very rare, but devastating if you miss it. How do you spot that amongst the enormous quantity of tired all the time? Or we're good at spotting thyroid. We always, I think every GP sees the tired patient, automatically does the thyroid function test, just as a way of trying to exclude that. But there's still things there. Palpitations, things like that, headaches. Interesting. One reassuring statistics about headaches is that serious headaches presents 1 in 1,000 in general practice, 1 in 100 in a specialist neurology clinic. So even then they're very rare, but 1 in 10 in accident and emergency. So the place, if a headache is bad enough to go to accident and emergency, it's interesting, let's start worrying about it. But if it goes to the GP, 99.9% are safe headaches. So the other problem I alluded to, and I'll mention, is complexity. And that is, again, a challenge for general practice. And I think also a challenge when we come on to the medical legal aspects, because what I want to touch on is the fact that guidelines, which are which are lovely things from the medico-legal point of view. There's nothing nice in the guideline that supports your case perfectly. But guidelines are guidelines, and guidelines are written on individual disease basis. So if you're looking at a COPD guideline, for example, or an asthma guideline, it will deal with the asthmatic patient. Or if you're looking at the heart failure guideline, it will deal with the heart failure patient. But it's not going to deal with a patient who's got heart failure, arthritis, depression, diabetes, all combined. And so that's where complexity makes guidelines more difficult. How complex is complexity? Well, it's all, as I said, a manifestation of the change in demographics. I will be joining the top bullet point by 2030. I hope I'll be joining that. But also, I'll be joining the top bullet point beneath it. I'll be joining the 20% population be over the age of 65 by 2030. Over 75-year-old population will triple, and over 85-year-olds will double. I mean, you know, I remember just the whole concept. Yeah, every so often I used to get an 85-year-old come in when I first started in general practice. Now that they don't come in, they bound in with their put their tennis racket down, you know, and they're telling me that they've sprained and their expectations, you know, are that, you know, I can't run the marathon anymore, doc, you know, at 85. It is a remarkable change in the number of people. And the fact is, it's not just the fact that they're much healthier, and I do work in an affluent part of the country, but they're healthier, but they live longer, and at 85, their expectations of health are high. And sometimes you have to say, I've got a little thing that I in some of my more cryptic notes, I say Samuel Johnson explained. And what that means is there was a quote by Samuel Johnson who said of women preachers, sorry, he said it, not me. He said of women preachers, he said, women preachers are like a dog walking on their hind legs. It's not they do it well or badly, it's the fact they can do it at all. And sometimes I say to them, look, you know, you're 85, you've had A, B, and C. It's not that you can't walk well or badly, it's the fact you can do it at all. You know, it's trying to temper that expectations. So I think that's an aspect. So there's the elderly. And let's have a look. This was a pay from 2007. So we've got to put on an extra 10 years, and I think makes a big difference to this. But look, by this stage, you can see that if you take someone in their 50s, half of the people have got one long-term chronic condition. Go on someone in the let's take 60. And if you go to the 50%, you know, have got two chronic conditions. And you can see the number of chronic conditions increases as you age. So this is just a diagram of a 2007. If you make that 2017, you'll find it skewed much more as the longevity of the population goes along. And this, I think, is a much better slide. And I'm sorry it doesn't project that well, but let me just take you through it very quickly. You've got the various diseases: coronary heart disease, hypertension, heart failure, stroke, atrial fibrillation, diabetes, COPD, painful condition, depression, dementia. And you can see it's rather like one of those football league table, who's playing who. But what it tells you is the coexistence between those. So a lot of people with coronary heart disease have got hypertension. It's common to a lot of conditions here. But let's have a look. A lot of people, 24% of people with coronary heart disease have got a painful condition. They're in pain all the time. And that's going to require some form of therapeutic intervention. 17% have got depression. 21% of people with stroke have got depression, and 31% of people with a painful condition have got depression. How are you going to jiggle that? How are you going to manage their depression? You know, and you can see that the interactions with these things, and that is a very graphic illustration of what percentage of people have got more than one chronic condition. And this is where it comes down to things not being as simple as they would seem in the guideline. Because you might want to treat their depression exactly as it tells you in the nice guidelines, but of course the drugs that you're going to use are going to upset their renal function, or the drugs you're going to use for their painful condition, you can't use the anti-inflammatory drugs as you would like to use because, of course, of their kidney function, their diabetes and their heart disease. And all these things have to be jiggled. And what's interesting is some research has been done into multimorbidity, and the conclusion came out from this that once you've got 4 chronic conditions, guidelines are totally useless, and you have to rely on doctors' intuitive response. Now, that's very difficult for you because I'm not sure how you present intuition as a valid clinical case, although I do. But the evidence is that it comes down to that doctor's intuitive ability to know the right thing to do in that particular clinical situation. So it causes complexity, causes problems for us, but it also can cause problems in looking at trying to actually say what is the right treatment, the most reasonable treatment for that individual condition. Okay, just a little political advert here, the fact that we are crumbling into a crisis. I'm sorry to put this to you, but the fact is general practice is under enormous pressure, and though perhaps that's not quite relevant to many aspects of this, and is well covered in publicity, the actual problems at the moment and the pressures on general practice is having a really detrimental effect on the workforce. Recruitment is such that very, very few people are going into general practice. Indeed, general practice and psychiatry have the two worst recruitment problems. Now, with no disrespect to psychiatrists, there's quite a lot of them, but you haven't got 40,000 of them. You know, enormous quantity of the medical workforce is general practice, and it needs to replace to survive, and that's just not happening. We've also got a situation where a third of all GPs will retire in the next 5 years. So forget the 2030 scenario, you know, with the elderly doubling, whatever. In the next 5 years, a third of GPs will be gone. And in fact, it's happening more quickly because of the fact that practice is under so much pressure that they're closing, and a domino effect. So if one practice fails, all the patients then have to go to the other practices which are just surviving, and that imperils them. So there is a very real crisis in general practice. And interaction is always a bit dangerous, but give me a guess at the average retirement age for a female GP in the UK. I'm going to pick on people. 55? Any other offers? Can I pick on you?
58.
58? I went embarrassing. 35. 35. And that's mainly because many female GPs will work, then understandably at some stage they want a family. They've got the family, they think to themselves, hell, do I really want to go back to that? And they stop working. So there is, the average age of retirement of female GPs in the United Kingdom is 35. So there, that's just to cheer you up a little bit and, and move on. So I want a lot of sympathy, and put that on your evaluation. Let your evaluation form be full of sympathy, even if it's no other objective judgment there. And I said workload, premises, and funding, of course, are the other things. Right, so that's a little introduction. What I wanted to do now, as I said, is to actually just take you through the way that the general practice notes work. And I do this because I'm not sure how many of you are familiar with the way we actually do this, and because most of the time you'll get it printed off as a printed form. So with the aid of some hopeful technology, I'm going to, perhaps I'll ask the man at the back to do this because he knows what he's doing, and I'll just put in this code which allows me to access my practice computer. Hold on. Is that working? All right, I've just got to go on to that, and that should work. Right, can we switch over screens? Things might happen. Perhaps the crisis slide is just sitting there. The hat will be passed around later. There we go. There we go. Do you want me to do anything this end? I'll just see if I minimize that. Will that? Right. Ah. Perhaps if I... Is that okay? If we... Oh, there. Quick advert from our sponsors.
Is that on your practice computer?
Yeah, we are. It's caller. Yes. If you're too stressed, you have to come and do that for me. Apologies. Oh, of course, it worked perfectly in the dress rehearsal. But
Okay, we've got a small hang up, so bear with. Sorry, I'll have to. We may not be able to do it for some reason.
wish I could talk. If it fails. I mean, you could all gather around here, but it's not really quite practical.
We may have to. It's locked, I'm afraid. So
if it's locked,
bear with
okay.
me. Hang on. Go back again.
Do you want me to?
2 seconds.
Yeah.
Sorry.
Any questions so far? That's brilliant.
How do female retiring on what sort of pension are they getting?
Well, the difficulty is not much, I think. A small pension, because of course the NHS pensions, like I think, if there's any judges, well, yes, judges, does pension do anything to your blood pressure?
Yes.
Yeah, I thought it might, yes. And I think to younger GPs it does as well, because I think there's a major problem. The pensions are nowhere near what they used to be, and I think the fact that they're willing to sacrifice pension and everything, it says a lot on that. The difficulty is that I think they are doing other things, but I think perhaps they come back later and work part-time, but mainly doing locum work, because it's just not so stressful. They haven't got the commitment, they haven't got the stress, which is one of the difficulties. And of course, a lot are going to Australia, a lot of trainees. I mean, when we're training practice, and when we speak to the trainees who come through, and very often the whole training scheme, perhaps 1 or 2 GPs out of 15 will go into general practice. Most will go off to Australia for a couple of years and try that. Many will stay there. Other people will do locums because they haven't got the commitment, and the workforce structure just isn't there. So there we are. Anyway, this is one of the practice computer. This is the EMIS, one of the 3 main software systems. So when you get your notes, I like EMIS. I'm an advocate of it, and I also like it from the medical legal side, because it actually prints out best. If you note from GP notes, you've either got system 1, which just goes on forever and ever and ever, and every nurse, whoever puts a bit of earwax out, gets sort of 5-line entry into that, and it goes on forever. There's Vision, which prints out very, very tightly, but doesn't give you complete records. You have to look for the blood pressure at the back section and things like that. And EMIS, which is the one I like, because it actually prints it out in proper consultation. So I like it both professionally and in both aspects of the profession. So there's a rather dangerous psychotic patient, a fake patient of our practice. And what you would do here, I can't really go into the appointment screen at the moment, but you've got an appointment system there. And what we would do, we would go to a consultation. So the patient then comes in, and if you go to appointment system, I will just flash this up so you can see one, and try not to stay for so long. But that's what it comes. And when the patient returns, just because they're real patients, you would then you mark the patient in and out. So you've got an electronic record of their attendance. And of course, as you're aware, the wonderful thing about computers is that the audit trail is always there. So if there's a disputed fact, did that patient attend for an appointment? Did they cancel the appointment? Did the patient turn up late for the appointment? Did the doctor ignore the patient? It's always there if you look for an audit trail of the computer system, because the computer system will say when the patient attended, when they were sent in, when they left, and when their notes were accessed. So every time these notes are accessed, it's logged in within the background audit trail. I've set myself up on here because I'm not registered with my own practice, but I've done it here, half for demo and half for just my own convenience to make notes. But let's go in, and what we would do is we'd go into my medical record, and you can see that my medical record there with various entries in that. And that's very much what you're getting it printed out as a printout. That scrolls down, but a GP then would see the screens. Now, very often, if you go to that, you'll see, as you can see, you'll see the screens 2 or 3 down. Important, because would the GP in that particular consultation be aware of what's happened in the consultation before? Generally, yes, because you can see, a couple of what's going on. You get a feel of the history there. I had a bit of problem with my it's my running. Obviously, had a running injury because I saw the physio and he wrote things about me on that. You see, and you can see all those things down there. So the GP would be aware, or should be aware, of what's gone on before, because that's often an issue. But you can see quite clearly, you'd have to be fairly, be fairly negligent to avoid the fact there's a screen in front of you with writing on it, and it's to be read because it's the patient record. So, so let's add a consultation, and I will just put that on there. And this again is important as to what's happening and how things work and how you get the notes, because all GP notes are read coded, that is coded, clinically coded. So if we actually put in, let's say here that I'm breathless. So you've got to be able to spell here. So any of you who've seen my notes or my reports will know that's not my best problem. So you can see now, why does it say have a chat to patient on the note? Do you think that's a bizarre thing for the GP to write? But the answer is it comes down from this box menu. Now on EMIS or all the other ones on system 1 notes, you'll find it's got a complex numero-digital code next to it. In Vision, you'll see it's set back at the first line, and here in EMIS, it's in bold. So the actual coding of the consultation will come in bold. So that's not free text. That's not what the doctor's written. It's what has been chosen as the reason for the consultation. So we can call it breathlessness if you want, and that will come down there. And you'll see that then that appears in green here as a code. And you can see here it's coded as an active problem. It's a first episode, and these are various criteria which are preset, which you can change. But you can see breathlessness is considered a minor problem which remains active indefinitely. If we take it back to something perhaps more serious, if we put diabetes in here, you will see that type 2 diabetes is if we put that, and this brings up various little triggers to remind me to do things. You can see it's a significant active problem. First episode, again, remains active indefinitely. So that means that this is, so it codes certain aspects of the record, and they will come in. You also, again, so this is often asked me or comes in confidence, why does it say first in brackets? Well, it is that because it's the first episode. Okay, review will often be that's already been coded in before. So this problem title is something which is there for audit purposes, audit of the medical record. It's a code that's in there and doesn't represent free text. Someone hasn't written how to chat to patients. Or I've noticed that you've got to differentiate between how to chat to patients, and there's another code which has how to chin wag to patients. And I'm not sure of the subtle diagnostic difference between the two, but there you go. Okay, and then you would put the history in, and again, this is where you tend to be able to free text history. So we could put, I know, polydipsia, weight loss or whatever, and that would then be entered into the history. And it's nicely coded history because that's the history is the part that the GP will actually take. And then we can then go on to you can see the examination aspects, and that will come in. Examination's got drop-down menus for coding, blood pressure, weight, height. And these are quite useful, I think, because very often it reminds you, the vital signs are so often missed. The vital signs are one of those things, so often if you're not sure what's going on, just take the blood pressure, pulse, oxygen, whatever's relevant, and often that can help to clarify the situation for you. And then, as well as that, you'll then got aspects such as, which I'll come on to in a moment. So family history is not used that much. Comment is quite a useful thing, and that's usually your formulation, your plan, whatever you're going to do. Comment is really your actions from that consultation. So from those three elements, the history, the examination, and the comment is very much the key aspect of the electronic consultation, and those are usually coded within the note, the paper note that you're going to get. But of course the whole thing is done electronically and therefore has a different flavor and a different nuance to it, and has a different accessibility. Tests, again, tests can take a large amount of space within the record, but if you want to have a test, we don't write bits of paper anymore. We all do it online. There I can see there's two hospitals we can get our tests for, and that comes up there, and then you can see we just tick box the test. I've had a case recently where someone forgot to do a test, and you can see, in fact, it was a case where someone, the GP, quite honestly said, I forgot to tick the box with the PSA on, and that PSA was missed, whatever. But you can see how easy it is to do, especially, if you tick a box and it doesn't tick properly. And that's a source of concern, that you've got to make sure you've done it right and ordered the right tests. The other interesting thing you'll have here is you can do things like referral. I'm not sure how many of you, are you familiar with choose and book referrals? You are. Okay. I mean, here you can actually do an NHSE referral. I won't be able to do it because I'm a dummy patient, so it won't go through. But this is a system which you literally can, you've got the facility to go online and to book the patient in with the consultant of the appropriate specialization in an appropriate hospital. And I find personally that's very useful because it allows you to ensure, first of all, that you've communicated that referral has been made. Also, it allows me to check that referral is in an appropriate time for my judgment for when it should be. So if I go on the system and I feel something is fairly urgent and needs to be seen within a week or two and I can get an urgent appointment, that's great. If I find that there isn't that, then I might have to use a different route of referral. It also means that I've communicated to the specialist in the hospital, I've communicated my concerns, the letter's gone electronically, it's all done and dusted, and there's no room for referral error. So I think the e-referral system is a very good thing because you know that the referral's been made, the patient's got a piece of paper in their hand with a date and time to go and see the specialist, you've communicated the information through, and I think that this is a major advance in terms of reducing risk for the patient and for the system within general practice. So that's where you are. Final thing is I'll just show you the medication screen as well, because this is something which sometimes is difficult to get from the notes that are supplied. Sometimes the medication is held within the record, sometimes not. But you can see the medication screen. You type in the, and I'll put you on aspirin, and you can see it comes up in a drop-down list. So I can give myself some aspirin tablets. I'll get these warnings, okay? So it'll tell me. The trouble is it's a bit like, it's overwarning. If you get it's perverse. If you actually get you prescribe and no red warning comes up, then I double check that it's safe, because every drug interaction brings a red warning, and it gets to be a bit like, I think that there's once a rail accident where they were so used to the things going, the driver warning cab bell was so often being cancelled and reset that the drivers didn't pay attention to red signals because they assumed it was always going to go off. And I think some of these systems are a bit like that. So I'll just come out of that. But, and of course, all of that after just, and there's lots of clicking, and I will just cancel that consultation for fear of my insurance premiums going up. So that really gives you a feel of that, and there's lots of other aspects to the medical record, and it's an intensely useful thing because notes can never get lost. Notes can never be illegible. They might not be. There might be typos, but they're not illegible. And of course, you've always got an audit trail, and you've always got coding. Just to say a few other things, you can see here, and this is relevant to what we'll be seeing later. I know tomorrow morning I've got 37 reports to go through. They'll have been seen by my colleagues, just seen to make sure they're safe to wait for me till I go in tomorrow, because I wasn't in surgery today. I do 4 days a week, have a Thursday. I don't work on a Thursday. So we know there that there's 37 lab reports waiting for me to check, and those will all be checked electronically again, and we can see that there's various other electronic messages like prescribing. Here again, prescribing is all done electronically. So in fact, the one thing one can say about, however much one jokes about NHS technology, is the fact that it does actually, in general practice, that the electronic record works very well, and is something which is extremely efficient in general practice. In fact, we couldn't cope without that. It also works very well because there's virtually, you can find virtually anything about that interaction between doctor and patient. You can see how, if there's a question of who accessed, I mean, the record, in this audit trail, it will see that Dr. Michael Ingram's record, which admittedly is a set-up record, was accessed today by remote control by myself on my login. So you've got absolute certainty of who's doing what to it. If a receptionist goes in to book an appointment, it'll be on the electronic patient record. And that is another level of information. Finally, and I was almost finally, but I've just had a thought that might be helpful. If I go to the taskbar, you can see here there's a load of messages for me to respond to. I'll come out of that just for confidentiality purposes, which doesn't help. Right, and that taskbar, okay, let's get rid of that. I'll close it down. That taskbar are internal messages, which I'll come out of the machine. And those will tell me, they're messages written to me by members of staff. So there'll be a phone call. Please ring back, Mrs. Smith. Please, Mrs. Burrows is worried about it's an ulcer on her foot leaking. Can you speak to her? Can the nurse go out? All those messages, internal messages, are done electronically in general practice, and therefore again can be traced and can actually give you more of a scenario when you're concerned about things. So I hope that's been helpful in highlighting the way the medical record works. I've probably got a few minutes left. Have I? I don't want to take too much time. I'll go back to the presentation, and I'll just go on a couple of things. I'm just going to briefly cover the areas that I see are at risk in general practice, and just take you through some of the crunch issues. So I'm just going to. Was there any questions about the electronic medical record while we're just changing over?
In the old days,
Yeah.
you used to have to wait, 10 days for blood results and X-ray reports to come back. How quickly are they coming back now that you've got this?
I would say that most routine blood tests are back within 48 hours. You can actually, and that's a good point, because I think this is related to a lot of cases. You can actually tell, there's two things I'll make here. One is, I'm digressing from your question, but forgive me. One is, remember that the date on the medical record is the date the test was ordered, not the date it came back. So when you get a printout, it's always related to the date the test was ordered. So if I saw my GP tomorrow and they wanted me to have a blood test, it would be the 17th of February, even though the blood test result might not come back till Monday or Tuesday. And that's a thing to remember. But it comes back within a couple of days, and we go through our blood results every day. A practice should make sure all the results are seen, so that any important or urgent ones are acted on by a doctor that day, to make sure nothing gets missed. And then, if like myself, I'm not on Thursday, it's left for me to deal with tomorrow. So usually 48 hours for routine tests. Other more complex tests can take a week to come back. X-rays, again, all come in electronically, the reports, and they vary. Usually, I would say up to a week for an X-ray can still be the case, but more routinely 3 or 4 days. And sometimes I'll even get an X-ray report on the same day. It just depends on how that's arranged. But all of that will come directly into the electronic records. There's no bits of paper, except sometimes in the private sector, because they haven't got access straight into the link. Does that answer your question? Probably gave you more of the answer than you wanted, but there you go. Right. I'm just going to talk about a few errors, and let's just talk of this. So,
the NHS is using different systems. I mean, I'm amazed you can go into the NHS and book an appointment. But I mean, are there things which aren't electronic and do they fall down? I mean, I send emails. You're not guaranteed that they get there. You're always double checking and sending things by fax or just letter or carrier pigeon or whatever. But you always try and make sure you're not just relying on electronic.
Yeah. The NHS referral system, the e-referral system, has got checks. When you get this code number, that's gone into the hospital system, so you can be sure of that. Yes, once we leave our environment and go out in the brave world, away from our surgeries into the big NHS out there, it's very much paper-based. I know the Royal Free, for example, have got a very good electronic diabetes system, which I know personally even talks to local GPs because they use the EMA system there, and they can actually interact with GPs' computer. But that's the exception rather than the rule. Communication is still very much in paper, but as Mark might allude to, they've got an excellent community diabetes system which interacts. That's the way of the future, but it still doesn't. They don't talk to each other. And the trouble is, hospitals still, seem to us rather archaic. Big folders of notes being carted around in certainly in our local hospital. I'll just touch a few areas of errors, and I don't want to overstay my welcome on this one, but let's just have a look at, I've listed a few areas here, and I'll just go through them because I've tried to look at where we tend to fall down. I think one of the great failures is failure to act, and I think this comes back in many ways. One of that is the fact that no one takes responsibility for a problem. Different GPs, nurses, whatever, see the problem, do something, do an investigation, it comes back, but no one actually grapples with an issue that is allowed to slide. And I think that's one of the common problems that occurs. So I don't know, it's abdominal pain, which is okay, but then it gets a bit worse. So you do a few tests and it's a bit worse. And no one actually gets around to saying, hold on, this is not doing what I expect it to do. This patient needs to be assessed urgently or whatever because I'm worried about it. It just goes on. Failures to visit or consult. Often there is a failure to visit, or a telephone call will come in and it's not dealt with properly. It really needs a consultation, but it doesn't get one. And I think the other thing is people missing important indicators. And it's not so much red flags for a condition, which does occur, but it's the progression of symptoms. It's the back pain, and they've got an MRI booked for a month's time, but they're beginning to get progressive symptoms. Then they're getting bilateral symptoms. Then they're getting motor symptoms. And no one's actually saying, actually, that's not good enough. We need to get them into hospital now. So that's the sort of flavor that happens. It's someone not taking the action, not taking ownership. The other thing is that there are subliminal rules, and this is where, and one of those rules is quantifiable, and it sort of comes into general practice. It's called 3 strikes. That is, you see you're seen on 3 occasions, and no one really knows what's going on. Then you need to do something. Okay, if you see someone the first time and you're not sure what's going on, well, that's general practice. A lot of patients, you've got a feel for it, but you're not sure. They come back a second time and you're a little bit on edge, but you still can't find anything specific. If they're coming back a third time, they need to be dealt with, either referral or investigated or admitted to hospital, depending on the clinical situation. But it's a fairly good rule. The SJNR rule is the most powerful indicator for serious pathology. Something's just not right. Okay, and I'm sorry to put it that way, but I'm sure, Mark, in training medical students in hospital, and I hope, you know, when the receiving doctor on the phone hears the GP saying, "I'm not sure what's going on, but there's something just not right." When a GP says that, it really means they're worried, and they can't put a finger on it, and that is a very, very accurate sign of something pathological going on. You don't know what, but if a GP says there's something just not right, okay, yeah, and okay, it depends on the experience and knowledge of the GP, but you have to take that seriously. Difficult to quantify. And something out of the ordinary, you know, someone requesting a home visit who never does, or a seemingly trivial presentation coming in someone who rarely consults. We're always wary of the person who hardly sees the doctor. Why are they coming? They never see a doctor. What's the reason there? And you've got to be doubly sure. And sometimes, you know, it's just luck. I had a case last month, in fact. I was out visiting another patient, and it was a busy morning, and I got a home visit request from a man who often does come and see me, but he never calls me for a home visit, or hardly ever calls me for a home visit. And I was out at another patient's house, and I thought, well, you know, do I go back to the surgery? He's only around the corner. I'll go there, and you know, because I was out anyway. And it was a sort of thing which, if I'd been in surgery, I wouldn't have left surgery for. And if I'd got that call, I probably would have left it after I'd done all my paperwork. But as it happened, he had bacterial meningitis, and I thought to myself, just luck. I mean, that was luck. So I should have put luck in there because, come on, I'm not. It's not that I could diagnose it over the phone, or it was something just not right, because, you know, he often consults, but you've got to have a bit of luck sometimes, and you can say that. Failure to act, we've got, you know, again, the NICE referral guidelines, which are one of the few ones written in stone. The NICE referral guidelines for cancer are ones that GPs all know and can recite in their sleep. And they know their 2-week referral pathways. And so that's quite a nice hard thing to look at. Delays in referral, and I think I've covered a lot of that. Some of that is inappropriate route of referral, you know, the urgent routine letter written and posted. Well, if it's urgent, why are you've got to do something more than that. Hospitals don't just give an urgent appointment because you've written urgent on the top of the letter. Delays of the communication of that referral. Why hasn't it been sent off? Has it been seen by if it's that urgent, are you checking the hospital's received it? And then sometimes you've got restrictions of referrals. Many CCGs now won't allow you to refer musculoskeletal problems without going through a referral management system, better known as a referral delay system, which is there to stop you referring, and it's a disincentive because it saves them money. And I said, no one taking ownership of a problem, I think, is a very important aspect. And it happens in all forms of life. Medicine is not an exception to that. Results, I think, are important. I've put up the guidelines from the BMA there. Essentially, the creed that is recited is, if you order a test, you are responsible for it. Now, it may be that you delegate that responsibility and the practice says that the duty doctor is the doctor responsible for seeing all the tests that come in on that day. And that's fine if that's there in that protocol. But fundamentally, the rule is if you order the test, you're responsible for it. And I think that's going to be inculcated more and more into the way we work in medicine, because it's only that way that the person who's ordering the test can act on it, and to maintain that responsibility, they've seen the result and said that's normal or it needs action. Failure to act on results is, of course, a major issue, and that's where things go wrong once more. Failure to listen to the patient, and I think that's, you know, there's some patients I listen to more than others, as I'm sure there are many people in your life you listen to more than others. But when a patient is worried about something or brings up a specific issue, then it is good practice to deal with that. And if that is something they're particularly worried about and you feel it needs referral or whatever, then you've got to actually say that patient's worried about it. Have I dealt with it? Have I excluded it? Have I reassured the patient sufficiently, reassured myself that that patient you know, has had their worries reassured? Even further, it's when other record, well, colleagues have taken a record and said, if no better needs referral, or if no better will need 2 weeks, or if recurs, if the bleeding recurs, needs a 2-week wait referral. You know, you're hostage to fortune if you ignore those documented things in the notes. So that's really what I'm saying on that thing. Continuity of care, we've already said that, and it's failure to take ownership of a problem, so I won't duplicate this. And I think the other thing that I want to emphasize is safety netting. Safety netting is a phrase which was developed by a local GP, Roger Neighbour, who put in the theory of the consultation many years ago when I was young, and who had this idea that at the end of the consultation, you're putting out a safety net to make sure that you are that you're catching anything that you've missed. And the way I look at it is making sure the patient knows your expectations. So I think, you know, this is abdominal pain. I think it's your old diverticular disease flaring up. I've put you on the antibiotics. I would expect that within 24, 48 hours, you'll start to get a response. You'll feel better. And that way the patient knows your expectations, you know, and what you're expecting. And if you're not behaving as the doctor expects, I think it empowers the patient to say, it's not doing as you thought, doc, you know, I will contact you. If it's not doing that, contact me, leave me a message, because then I'm concerned. You know, it's the way that's done. And I think it's very important to communicate that, to make sure the patient understands the key points of your concerns. And there are often uncertainties. We as GPs are expert risk takers. We take the burden of risk. You know, I'm not trying to make myself, but we do take the burden of risk because we're getting all this unsorted stuff, and we've got to take the responsibility of making the call. Is this serious or is it not? Does this need action? Does it not? And we're always taking risk, and safety netting is the way we take out insurance. We mitigate that risk. And it's very important that we keep our eye on the ball until that ball is safely caught. And if that ball starts to wobble or anything like that, I'm going to lose this metaphor soon. But if that ball's not, you know, then we should get worried, and we should then realise that we can't afford to hold that risk anymore, and further action needs to be taken. Specialist opinion. I think this is an interesting one, and the question is, how long can you rely on your specialist colleague's opinion expressed in a letter or whatever, that the situation is A, when you know the specialist said it was that they have a perfectly clear thyroid condition, there's no other worries. How long can I rely on that for? What other circumstances have occurred since that patient's been seen by the specialist? That's a very difficult question, and I think one of the most difficult. How long is a GP entitled to rely on that specialist diagnosis? Even and if we take it out of the outpatient setting, it's even more difficult, because I'm afraid the way that hospital medicine is responding to the pressures is that patients are under enormous pressures to be discharged from hospital. The day when patients used to go into hospital ill and came out perfectly well have long gone. They go in ill and come out, if you're lucky, slightly less ill to recover at home. And how well can you rely on that diagnosis? Again, a pocketful. But I sent in a lady who I was worried about, and I sent her to the surgeons, and she was sent out that day saying there's nothing wrong with her. And I was called back to see a week later, sent her back in, and she did have obstruction. She had a tumor, she had an operation, and all these things. Now, the difficulty is that's, and this is not casting blame in other areas, but it is the system. Whereas you used to be able to rely on the fact they'd been seen in A&E and therefore they'd been well assessed. You've got a situation in general practice which adds to your stress, adds to your uncertainty, and adds to your risk-taking thing, where you can't be sure that they, just because they've been seen in A&E, they've been fully assessed. You can't be sure that they, just because they've been referred on a 2-week wait bowel cancer screening, that you've sorted their tummy problem, because they'll just get a colonoscopy, there'll be no tumour there, they're discharged back to you. It hasn't actually helped you much, because the system is there for 2-week wait, do a colonoscopy, nothing in the bowel, therefore it's okay. It's not that holistic approach anymore, because targets have changed that. So there we go. Communication will, there's lots we could talk about, but I won't, because it's time for me to wind up. So my last thing is briefing GP experts, just a little message, what we need, okay? And the difficulty, we're used to working with these computerized notes, and it's very difficult because there's lots of different ways these computerized notes can be printed out, and it's trying to get out all the notes. It's trying to get out all the letters which are scanned into the notes and attached to them electronically. They're all there. It just has to make sure they're all disclosed. And also, as I said, internal messaging. Obviously, we like our notes paginated, and just remember that GPs never see x-rays, or hardly ever. I actually had saw an x-ray of my foot, and even I could see it was pretty arthritic. But other than that, that's the first x-ray I think I've seen for about for the last year. So we really, very nice of you to send us discs and things like that, but GPs don't look at x-rays. Never trust a GP who gives you an opinion on an x-ray, because they've never done it before. So you don't have to worry about that. So there we go. And thank you very much indeed. And I hope that's been helpful.
I hope everybody asked questions that they wanted to ask as we went along with it. Thank you very much. That's very interesting. A friend of mine now has a GP who she doesn't trust at all, and it says, a big notice in the waiting room, we will only discuss one issue with you.
I'm glad you brought that up, because I don't think that's fair. I don't think that's fair. I think people have got more than one issue. You may, and there's a lovely phrase that I heard a GP use, who said, you and I have known each other for 10 years, you'll probably be here for another 10 years. We've got plenty of time to do the background issues. Let's focus on what's important today. And I think that's a much nicer
better way of doing it. Thank you very much. Thank you. Our next speaker, Dr. Mark Vanderpump, is going to talk about diabetes. It says on here that he's obviously, as we've heard, a specialist in thyroid disease as well. It says thyroid disease, the facts, as we published the author. So
it's my only book on Amazon.
In our post-truth era, it's good to know that there are some facts out there that we can rely on. But today, diabetes, I had a quick look at the PowerPoint. It really is going to put you off jam donuts.
Yeah, I won't mention which member of staff I put in one of the slides. Okay, there's that one. Is that one, I think? You're just on it? Okay, thank you very much for inviting me, and it's quite nice to see sort of some of the addresses that write to you as you walk here today. And so I was asked to cover the whole of endocrinology, so I thought I'd be a bit presumptuous and hope you might invite me back next year. So be careful what you say in the evaluation. But I thought I would divide it up into diabetes and endocrinology, because we do both. And diabetes is a big enough subject in its own right. I thought that would be a start, and probably is the commonest thing I'm asked about in terms of reports. So in terms of what I'm hoping to cover, it's really just to give you a feel for what diabetes is, type 1, type 2, and how it's managed. And the main issue, I suspect, in terms of what you'll come across is the risk of complications in diabetes, which really defines diabetes for what it is as a long-term condition. And then in my last slide or two, I'm going to just cover just some of the broad areas that I've been asked to provide an opinion on in my reports, and we can discuss some of those, or things may ring a bell if not your cases, but in terms of the general areas, in terms of how you approach it. But in terms of the key areas, it's diagnosis. I'm asked a lot about life expectancy, pregnancy, clearly a big issue, and I think increasingly now diabetic foot disease is becoming quite a big part of our work. So just the simplistic, diabetes is a problem with your sugar, and you can have two problems. You can either not produce insulin, or the insulin you make doesn't work very well. So there's a problem with secretion of insulin and insulin action. And the bottom line is that if you've got diabetes, the glucose doesn't enter cells, you don't have fuel, and as a result, your blood sugar starts to rise. So it is a disease defined by having a high blood sugar. And so you have this abnormality of carbohydrate metabolism, and then you'll be aware in the press, it's divided into type 1 and type 2. And to some extent, they are different diseases, and I'll mention how they're different, and also how actually they are quite, how they are similar in some aspects. But they defined by this problem secretion and problem resistance, and we have classical symptoms. They're called hyperosmolar symptoms, and that's what drives the thirst, passing lots of urine, getting up at night, the weight loss. These are described as hyperosmolar symptoms that are shown with the classical presentation of diabetes. Although, as you'll find now when you're looking through reports, actually it's fairly rare that patients present with symptoms these days. Most of the time with the frequent blood tests, people have been found on screening. We have clear biochemical criteria where you have diabetes or you don't. And so now the WHO defines us as having diabetes, so there shouldn't be any doubt. And as with all things, there's a white area you haven't got it, a black area you have, and there's an area in the grey area in the middle where you've got a pre-diabetes syndrome where you're defined as being at risk. And that's called impaired glucose tolerance or pre-diabetes. So as you're probably aware from the press, it's becoming a big problem, probably about 5% of the population and increasing. The vast majority of people are going to have what's called type 2 diabetes. And there's this estimation that we're going to be looking at 5 million people with diabetes by the end of 2025. Now, type 1 diabetes, therefore, is defined by the young people who get diabetes. They present with complete pancreatic failure and they need insulin for life. Type 2 is the one we're more normally associated with lifestyle factors, presenting slightly older. But again, the definitions are changing, and so it's recognized that youngsters as young as 10 are getting type 2 diabetes when they're significantly overweight, and that type 1 diabetes can occur in the elderly as well. So these strict definitions are changing. And the main problem with this diagnosis is not only that it consumes a lot of resources in the NHS, and it's estimated at over 10%, but actually it's the complications of having that sugar rise for a long time that causes morbidity, disease associated with the condition, and also a reduction in your life expectancy, depending on your age of diagnosis, of up to 15 years. So diabetes to some extent, and also if as soon as a member of the public hears they've got diabetes, it's really defined by its complications. And so there are a whole list of complications, from stroke to blindness, heart disease, kidney disease, commonest cause of needing a transplant in this country, erectile dysfunction, nerve problems, blockage of the blood vessels, peripheral vascular disease, and the combination of these two resulting in that complex morbidity of diabetic foot disease. So there's a whole list of complications, but there's no such thing as mild diabetes. So patients will think, okay, I'm controlling my blood sugars with diet alone, therefore I'm only mildly diabetic. But actually your risk of death is the same as whether you're on 5 injections a day or actually just on diet controlled. The sugar level doesn't define your life expectancy. The problem you've been given with the disease is what's defining your life expectancy. So we try and really avoid that concept of people thinking that it's only mild and they don't have to bother. So the two complications that we talk about are defined by the size of the blood vessels. So you have microvascular, which are small blood vessels, and these are the main defining complications of diabetes, affecting the eyes with bleeding at the back of the eyes and hemorrhage and loss of vision. Kidneys, where you have increasing amount of protein produced in the urine and ending up with renal failure and on dialysis with requiring donor. And then in the problems with the feet, in terms of looking at problems with foot ulcers and amputations. Macrovascular is defining myocardial infarction, stroke, and also difficulty with blood vessels to the feet as well. So this is how we're defining our two complications. Now, one of the key things in diabetes control, and this is how we know whether someone's got good or bad control, and you'll see things, well, he had good control or he was terribly controlled, is that we have a little lie detector and a test which tells us whether anyone is actually good with their blood sugars. So in the old days, people were given a meter, they filled in their diary, they turned up in the clinic, 667777, and they'd obviously made it up on the bus on the way in. So we now have a measure of how good your blood sugar has been for 3 months before you attend for that clinic. And actually, whether you have a good weekend, you went on holiday for a week, all the excuses you're given absolutely probably make very little difference to this measure of your blood sugar control. There is a weighting for the month prior to the sampling, so if you had a terrible month or a good month, you might bias the results slightly. But this is now how we're actually defining diabetes rather than your blood sugar. The glycated hemoglobin, HbA1c, is now officially how we're defining diabetes. So in a sense, it gets away with having whether you fasted or not on a particular day. So the correlation is quite accurately, between what your blood sugar is averaged over that 2 or 3 months with this level of glycation of the hemoglobin. This is the glucose attaching to your red cell. And it's defined as a percentage or a millimole per mole. And you can see this correlation. These are the people, individuals with their higher and higher average blood sugars, defining their HbA1c getting higher and higher. And so this is how we know whether you've got a good average. It's a bit like saying, what's my average temperature of Britain been in the last 3 months? It will tell you where you are. If you've had a good weekend or a bad weekend of temperature, it will still tell you roughly where you've been for the 3 months. So the importance of this is that all the studies now, and there have been some long-term studies, have shown that the worse that blood sugar average, and this is obviously reassuring for diabetes physicians, that makes me feel like we're going to be doing something, is the worse your blood sugar result, the worse you have in terms of your risk of all these various complications. At the mild level, you're talking about leaking of protein without anybody noticing it, even on a dipstick, early changes at the back of the eyes, maybe just some pins and needles in the feet, to more significant major complications correlating with this level of blood sugar control. And as Mike was saying earlier, with the duration factor, now that people are living a lot longer, people are now having raised blood sugars for many, many more years. They're not just presenting, when I started out, with a heart attack on ITU or CCU and dying with just being told they've got diabetes. They've now got diabetes for 20 or 30 years. So all these complications are starting to appear much more commonly in the population just because of the duration of diabetes of the patient group. So I mentioned type 1 diabetes, and this is now just to talk a little bit about the natural history. In terms of the genetic risk, we also think type 1 diabetes must be much more genetic, but actually it's not so genetic as type 2, which we'll describe. And I usually say to a parent, if they've got diabetes, the chance of their kid having it is 5%. So if they've had 20 kids, one will get it, but they don't know if it's the first or the 20th. Not as common as you'd think. But you have you're born with a genetic predisposition. You meet an environmental trigger. Something kicks off your immune system. It destroys your pancreas, often over about 6 to 9 months before you present with diabetes. You then have a transient honeymoon, which is a year or two where things seem to improve. Then you enter this chronic phase, often a year or two after the diagnosis. You have no insulin, you need injections for life. A very clear sort of diagnostic pathway. One of the problems in type 1 diabetes, of course, you need insulin. And the key issue, and particularly in the medical legal world, is that not only are you worried about these complications that are occurring with poor blood sugar control over many years, but you also have a much more key problem associated with the treatment of the condition itself. That includes hypoglycemia and even death. So the big problem that people with type 1 diabetes live with is, on the one hand, trying to normalize their blood sugars to reduce their risk of their feared long-term complications, dialysis, needing a new kidney, having an amputation, versus their day-to-day battle with fighting with a low blood sugar at the same time. And it's the low blood sugar that actually causes far more morbidity and mortality in the short term and these longer term risks. So hypoglycemia, and I think again particularly a key issue, particularly in hospital patients that we'll mention, has a whole group of problems that you can be associated with. And just to remember, in the elderly, it's actually one of the commonest cause of falls in the elderly presenting to A&E. So the impact of the treatment of diabetes has to be weighed against your prevention of long-term complications. So in terms of the principles of treating type 1 diabetes, we've obviously got to optimize their blood sugar control to reduce their risk of complications, and that involves control of blood pressure, stopping smoking, control of cholesterol, etc. And what we're trying to do in our clinics is see people over a long time, get to know them, and actually try and detect complications before they're happening or as they're happening, so that you can actually intervene and stop complications progressing. One of the key issues that you'll see with many type 1 patients is a very high prevalence of eating disorders, and some, particularly young women more than men, although it does occur in men as well, use their diabetes as to weight control, because they know if they run poor blood sugars and become ketotic, actually they start losing weight. The moment they regain control, they actually put on a lot of weight, which is obviously not what they're wanting at a particular time. So I normally assume any type 1 female has an eating disorder until proved otherwise, because it's so common in that group and population. Major issues with regard to preconception and pregnancy because of the morbidity associated with pregnancy, both before the pregnancy and during, in terms of both the fetal and the maternal outcome. And in our practice now, the big emphasis is on multidisciplinary care. Most patients with type 1 diabetes should be being seen in a hospital environment, and access to various education from dietitians, nurses, etc. And importantly, if possible, psychological support as well. So the big emphasis is rather this group of patients, 5 to 10% of the diabetic group, are normally managed in a hospital environment. So in contrast, type 2 diabetes, which is the one that people sort of know a bit more about, because everyone just thinks, oh, you're going to put on weight, you get diabetes. This one's actually got a bit more genetics than the type 1. So if you've got a mother with type 2, you've got a 50% lifetime risk of developing type 2 diabetes, and a concordance with identical twins as well. Now, as you can see, in contrast to where this was in type 1, this was months. This is over years, and you can start to pick up people 10 years before they were going to get type 2 diabetes that they're at risk. You can start to see their pancreas beginning to fail. It's a bit like having an older car where you're having to push harder on the pedal to keep to the same speed as everyone else, and you can pick up that process 10 years before the patient is diagnosed. And the irony is, at the time of diagnosis, they're making more insulin than the person who hasn't got diabetes, because their insulin just isn't working. So they're pushing hard on the floor and they're not getting any response, and that's when their sugars start to go up. The problem with that, therefore, is that often people have had diabetes for many years before they've been diagnosed. And the usual rule of thumb, and that people quote, and it has been looked at, is that you may have had type 2 diabetes for 4 to 7 years before you become symptomatic. So when you're looking at patients who are complaining about things and in terms of causation, you have to be aware that there's a lot of things. Someone's in a car accident, they get diabetes 6 months later. Was the car accident causative in terms of diabetes? You're looking at a process that's been generated over many years prior to that moment. And then over time, you then see this deterioration. So that's why over the next 10 to 20, 30 years, people need more and more interventions with medications. And after about 15 years, about 50% of patients with type 2 diabetes normally need insulin therapy, because the tablets are not working anymore. So you're probably down to about 20% of your pancreatic function at diagnosis. And once you go down to 5%, you're going to need insulin therapy, and tablets, no matter how many you take, are going to be effective. So I won't mention which member of the audience provided this picture for me just before we came in. But this is this key phenomena, which I think is a great thing in terms of all the technology. The tape measure is almost the only thing I carry with me now, because you've got some clear area where this fat in this sort of gentleman's belly is what's telling us he's going to get diabetes. And when you look at the scan, you can see all this white stuff here. This is intra-abdominal fat. It's not your love handles that you squeeze. This is all the fat that's inside your gut, and that collects when your insulin doesn't work anymore. So when you move above a certain waist, you are starting to collect enough fat that demonstrates that your insulin is becoming ineffective. And I can tell you the waist circumferences later. I don't want to embarrass anyone. And the other thing for men to realize is that when you go into the shops, they're slightly flattering, and that everybody's waist is about, I actually asked 100 men in a row, and everyone gave me a waist that was 3 or 4 inches less than it actually was. Because everyone, of course, wears their trousers around their hips and not the widest bit of their belly. So add 3 or 4 inches over to whatever you think you are. But the key measure is 36 in Marks and Spencer's. If you go above that, you've got trouble. So there are actually now, from primary care data, and you can see from what Mike showed earlier, that actually we now can actually calculate your risk, not just with a tape measure or with measuring your fat, but actually using some primary care tools that have taken patients with real data and looked at their risk of getting diabetes. So now if I'm asked, well, was that person going to get diabetes? There are actually some real sort of figures that I can give you in terms of a risk over the next decade or so in terms of getting diabetes, which is one of the problems I have in my specialty is everyone wants to know percentages, blah, blah, blah. So now we're starting to be giving you some real percentages of what your risk of getting diabetes. And it's based, as you might expect, on your age, gender, ethnicity, postcode, and family history, blood pressure, whether you've had a heart attack or stroke. So there's some nice key ways for us to estimate your risk. So as I've said, in type 2 diabetes, as in type 1, you are defined in terms of the long term, in terms of your risk of complications. And helpfully, very much like in type 1 diabetes, it was confirmed that every time you get an improvement in your HbA1c, you start improving your risk. So therefore, the key thing is get your blood sugar under control, control your blood pressure, control your cholesterol, and actually you're putting yourself in the best point in terms of reducing your longer term risk. One of the key things to remember, however, is just lowering your sugar by itself probably doesn't need, it's probably not important enough. You probably need a good sugar for 15 years to live any longer. So you're 75 and you've got a slightly bad blood sugar level, actually reducing it for 30 quid a month with a tablet will not make you live any longer. So I think it does actually mean that more and more we're individualizing care and choosing our patients who actually need the blood sugar intervention versus those who can be left at a more relaxed level, because not all treatment options are safe, and as we've seen, actually hypoglycemia is actually a cause of more problems in the elderly than it actually protects them in terms of their long-term health. So unlike in type 1 diabetes where people have insulin and nothing else, the treatment options for type 2 diabetes are much more complex. So not only do we have our traditional lifestyle factors such as weight loss and through exercise and diet, but we have ways that we can actually increase insulin production, we can increase glucose excretion in the kidney, we can obviously replace with insulin, we can use gut hormones to help insulin work. There's a much more wider complexity now of the various drug interventions for type 2 diabetes, which makes it a very complex disease. And so unfortunately for the GPs, where all this diabetes is being chucked out into the community, just at the point it's becoming really complex, they are struggling a little bit with all these various treatments in terms of how to manage them patients, because they are all individual. You can use all of them, and knowing which ones to use is quite a skill. So those are sort of an overview of type 1 versus type 2, and some of these acute emergencies are going to be the things that tend to provoke legal issues. So I just emphasize this risk of hypoglycemia, how you assess risk, and in particularly in the elderly where you have falls. We have patients who present with diabetic emergencies where their glucose levels build up and they develop acid. Could have been stopped. What were the interventions? Increasingly in hospital populations, you've got use of steroids and high nutritional feeds, which can push people into diabetes even though they didn't know they had it. There are problems with some of the other medications such as metformin, which is one of the common tablets. But an overall feeling is that the staff looking after the people with diabetes haven't got a clue about diabetes. And so in terms of your inpatient stay, the best thing to do is to have some sort of certificate saying I'm allowed to look after my own diabetes and take it away, because as soon as the hospital gets involved in managing the patient, that's when the chaos happens. Non-specialists start putting insulin drips up, sugar up, People are left on infusions who don't need to be. It's a major cause of morbidity and mortality and trips by the medical director to the coroner's court almost than any other specialty, and is now increasingly being recognised as such. And just to say that unexpected outcomes are common. Even the most experienced, you can say, I can't believe that whatever we did there made that guy hypoglycemic. There are so many factors involved in keeping your sugar level up. It's actually really difficult to manage in a hospital situation. I just want to emphasize, I've just left some quotes. Obviously, there's some rules around driving and diabetes and various classes of drive, whether you're needing insulin or not, just to remind you in terms of medical legal issues. And that we as physicians do have a responsibility now to actually inform DVLA if we feel that the patient is not going to actually inform DVLA themselves if we think there's a problem. And that usually relates either to hypoglycemia or difficulty with vision. I mentioned pregnancy earlier because obviously it's a cause of big claims when it happens, and there are still some key things that can go wrong. In particular, allowing a woman in a hospital to develop a complex sort of diabetic ketoacidosis, a complex problem with diabetes in pregnancy associated with fetal death. A problem that we particularly have is that the key areas in that first 12 weeks of the pregnancy when the baby's being formed is that getting good blood sugar control in that 12 weeks is completely important in terms of the development of the heart and brain. And so preconception control is one of the key things. And actually you're trying to get a mum to say, look, for the 3 months leading up to the pregnancy, get your sugars under control, and then actually you stand a better chance. There's too often people are turning up at 6 to 8, women are turning up 6 to 8 weeks into a pregnancy, and that's the first time they've addressed their blood sugar control. Again, I've just quoted some nice guidance down here, which again is one of the things I know you love in terms of quoting. One of the other areas that's increasingly common now is diabetic foot disease, partly because increasing length of time and duration of diabetes, and it's a really important cause of morbidity. The prevalence of diabetic neuropathy, which is actually this nerve damage associated with diabetes, is common. And if you keep going, look for it, you might find it up to 50% of patients over 60 years. And this means that you have a high risk foot for developing foot ulcers. The lifetime risk is about 10 to 15%. So if you're getting diabetics living a lot longer, then actually you're going to have a lot more actually getting a foot ulcer. And of those foot ulcers, it's estimated that about 20% progress to amputation. So that's below your magic 50% line. So if someone has an amputation, and the issue is why did that happen? Because you can always go through the history and actually find out things that didn't work out. And so actually it's quite a good way to actually say, this should never have happened. That shouldn't have happened, an amputation. Why did that progress? Now, sometimes the key issues we'll discuss is the blood supply or the nerve supply, but it's a key issue now because a lot of patients are not being seen in specialist clinics. They're being pushed out into community podiatry clinics where sometimes the supervision isn't so good. Big cause of NHS spending, and to cheer you all up, there's a nice guidance as well. Now, foot ulceration is therefore quite a complex. You've obviously got to have diabetes for a while. You've got some other factors such as smoking, blood pressure and high cholesterol interfering with the blood supply. But you've got this key issue of nerve damage to the motor nerves, the sensory nerves. There's also a concept of autonomic nerve function, which is where you lose your involuntary nervous system to not help in terms of the small blood vessels. But the bottom line is that you don't feel your foot, or you change the shape of your foot. You therefore get pressure areas that you didn't have before, which therefore get rubbed, you develop blisters, they get infected, and you're left with a chronic foot ulcer. And so this is this sort of big problem that's trying to prevent. The big issue therefore is prevention, and that's why all diabetics are supposed to have their foot inspected every year and have regular foot education, etc., to prevent all this happening. So what predicts that 20% who get amputation? Well, having had an ulcer before, if you've had one the other side, the implication is if you've had bad enough disease to have one leg off, then the other leg is going to have similar disease. There's presence of neuropathy. One of the key issues, and when I talk to my vascular surgeons, is the presence of peripheral vascular disease, because the one thing that can change the outcome in a major fashion is reopening blood vessels that are closed. Sometimes the neuropathy can be so bad that there's nothing you could have done. The key issue is whether there was a correct assessment of the peripheral vascular supply to prevent the deterioration. And one thing that's often ignored is poor glycemic control, i.e. was the diabetes attended to at the same time as the foot? Because you just imagine this foot going around these various clinics with the rest of the patient actually not really being that attended to, and that would include their blood pressure and other factors. So in terms of our management of the foot, there are various stages from early to severe, and what you're trying to do is prevent your progression through these various stages with patient education, what we call offloading, where people have support boots, where they're removing the pressure from the ulcer. We're improving their diabetes. We're really looking at their blood vessel control. If they've got a wound that has been properly assessed on antibiotics, on the correct antibiotics, that they've had regular swabs, and that they've had x-rays and scans to check the infection hasn't spread deeper into the bone. One of the key areas I've seen a lot of recently is this concept of a Charcot's foot, which is when you just have a complete neuropathic foot. And I would describe it a bit like having a mini earthquake in your foot, in that all your bones get disrupted, you've got no nerve supply, and you're basically given a new shaped foot. Therefore, all those areas that you didn't have exposed suddenly become exposed. They've got poor blood supply, they've got poor nerve supply, and therefore you are therefore a sitting duck for getting a new ulcer. And one of the key issues can be that it's often difficult to distinguish from osteomyelitis. So you have patients who are called one and not the other. The managements are different, and so if the outcome is bad, the issue is going back to say who made the decision that this was osteomyelitis, or who decided this was a Charcot foot, or vice versa. And this is just to show, I thought I'd better put one foot slide in just to cheer you up. This is a Charcot's foot, just showing that sort of complete disruption that you see in the foot of a patient with diabetes, and you can see how this area here is getting the pressure now, and that's what's going to ulcerate and cause a problem in the future. And as soon as that gets ulcerated and infected, then you know you're in for the long haul of long-term treatment. So in terms of what matters and what you should be looking for in a diabetic foot is looking, is there good examples of good practice in terms of a multidisciplinary approach? Are there various members of the team actually interacting and saying, have we looked at the blood supply? Are we looking at the sugars? And rather than just being a podiatrist, seeing them once a week in a foot clinic. Is every time the infections happen, they're getting prompt and adequate treatment? Are people being discharged to community appropriately and then not coming back appropriately when things aren't always happening and not going the right way? And as I said, your ability to fight infection requires on a good blood supply. It's amazing how often I see diabetic foot patients who have never had a proper vascular assessment or an incorrect one, where actually opening up the blood supply would have been the major issue. And that's probably the commonest reason I've seen that patients progress to an amputation in error. And it's a pretty miserable disease, because once you've had your amputation, there's a very high mortality rate within 5 years. And so this is actually a major sign that probably your body as a whole is failing, that if your blood vessels are that bad in your feet, that actually that represents what's happening in your heart and your brain and other bits. So again, there is now, I'm sorry this is so small, but there is again an indicator of what your risk is. So if you're saying to me, okay, that guy went to a swimming pool, cut his foot, he's got a foot ulcer, an infection, what was his likelihood? We can now actually tell you what his risk, although we can say he's got a 15% lifetime risk, we can now give you a 10-year risk of what his risk would have been of amputation if just from his pre-incident factors. So again, that allows you to start quoting, well, look, he only had a 5% risk, he's now had an amputation. So it does actually give you a bit more data to play with. And you could also look at blindness and heart failure with some of these web-based programs as well, all based on primary care data from the UK. We've not mentioned renal failure so much, but again, it's bad news. And you can see that your projected year of life when you're on dialysis is in the 5-year range. So it's, again, these outcomes represent your longer term morbidity and mortality. The mortality of diabetes is from macrovascular disease. That's from heart attacks and strokes. So the other complications we've been talking about are what makes your life miserable, but the reason you die is from a heart attack or a stroke. And so these long-term complications such as amputation, blindness or indeed renal failure represent where you are in your disease in your natural history and reflect that actually on average you're in the 5-year to go range. And so it does mean that in terms of some of your causation cases that actually you've got relatively little life thereafter that you would have expected no matter what the outcome was. And again, we can start to have, I've just sort of shown two examples, there are reasonable data now looking at lives lost from diabetes from your age, but the general view is that probably you're going to be quoted to be 5 to 15 years of life lost depending on your age of diagnosis. And it would depend on other factors such as smoking, blood pressure, cholesterol, etc. So it's in that sort of range when I'm asked about life expectancy. And you can also see some life expectancy now data from actually when you present with a myocardial infarction. So if you're 60 and a woman you present with a myocardial infarction, you've got an 8-year expectation of life or death. So it's actually much more meaningful figures than we've had before. So what do I find are common issues in diagnosis? Sometimes it's the delay of diagnosis. Did that fact that the sugar was in the notes and was 11 in 2006 and wasn't noticed till 2011, has that actually made a difference to the patient's longer term outcome? Did it matter that she was labelled type 1 or type 2? Patients get really hung up on whether they're type 1 or type 2. It really matters to them. I think they assume type 2 is all, you know, lifestyle. Type 1 has been given to me, I've been unlucky. So actually psychologically they feel better. There's a real issue with how diabetes is supervised in the community and the hospital. Look at this multidisciplinary team and environment and what access did the patient have, particularly the youngsters poorly attending clinics. I always wonder, you know, I'm doing a case, if a patient repeatedly doesn't attend for an appointment, how much can the doctor be criticised when that person hasn't attended or been discharged from their clinic? We talked about life expectancy. A lot of the time we're talking about the morbidity of predicting working life years. And I tend to work in decades and say, well, look, if your life expectancy is still 70, you're probably going to have 10 years of ill health before that probably will stop you working. So you can't really be expecting to be a full-time lorry driver at 65. You probably would say, okay, between 50, you know, you might even say between 55 and 60, you're on limited sort of duties because you're not going to be fully active. So it's trying to get a feel of what a patient's lifetime will look like working back from their life expectancy. Obviously, inpatient deaths are key, both in terms of high sugars or low sugars. Did hypoglycemia result in an RTA? It's quite common that diabetic patients will use hypoglycemia as a reason for something happening. And you often have to look at their risk of hypoglycemia, where their blood sugar was before and after, what they documented, and how likely hypoglycemia was at the event. That was because you're usually relying on the patient or the claimant or the defendant, actually their history of what they happened at that time. We've mentioned about pregnancies. We've mentioned about amputations and osteomyelitis, bone infection, and this complex condition called Charcot's foot. And I think, as I said, particularly the diabetic foot, there's always a lack of recognition of the high-risk foot. And that's usually now because a lot of foot care has been done in primary care, and you see all this sort of lovely data collected, but no one's actually told the patient that their foot's at high risk and they've not had anything done about it. A lot of inadequate antibiotic treatment, both in A&E and primary care. It's amazing the number of people who just get sent home on a 1-week course of antibiotics without any follow-up. Very little attention to blood sugar control if there's evidence of infection. The NICE guidance says that a diabetic foot clinic, and this is of most hospitals now, should be able to accept a referral to a clinic within 24 hours or the next working day. There really is no reason for a diabetic foot not to be sent for an initial assessment to a specialist diabetic foot clinic. So a lot of the time is involved in terms of care pathways, but I think they are improving. So I think that's a lot better than it was now. But the advantage of that foot clinic is that you then have this specialist multidisciplinary team approach where you have the vascular surgeon, the podiatrist, the diabetologist, all working together to actually provide a management plan that they don't get when they're just sort of lingering in the community, continuing on their antibiotics. A lot of the time, poor outcomes, they've ongoing infection, and no one's bothered to relook and do an MRI scan to confirm that actually the infection is spread to bone, and actually the outcome's going to be a lot worse, or that treatment needs to be intensified. And I come back again to this often lack of a vascular assessment or involvement. So in conclusion, I hope I've given you an understanding of diabetes and why it's important in general medical practice and therefore medical legal practice. There is this difference between type 1 and type 2 diabetes. The key issue in diabetes, whatever type you have though, is your complication risk, and that's mostly now I think diabetic foot disease more than any other issue. The medical legal issues are often diagnosis, when did it make a difference? I'm often asked about life expectancy, where the claim has got nothing to do with diabetes, it's a coexisting condition, therefore it's in terms of assessing quantum, and particularly in morbidity in terms of a person diagnosed at a young age, how long they would have expected to work. We've got two acute complications that are often poorly managed both in primary care and in the hospital. We've got the issue of pregnancy and the impact on the baby's development and birth outcomes. And then our main issue is whether complications have been found early enough and what could you have done to prevent their progression. So thank you very much.
Has anybody got any questions? Has anybody got any questions? I told you, it put you off your donuts.
You mentioned that
you mentioned that people who have diabetes are at a greater risk of getting strokes and heart attacks. Why is that? Is it because the blood's more sticky? Do they clot easily? Are their arteries furring up?
Yeah, so it's just premature atherosclerosis. And also in type 2 diabetes particularly, there's the sugar bit. It's a bit like one of those old-fashioned Venn diagrams. Sugar is just one of the circles. So another circle would be your blood pressure. Another circle would be your abnormal cholesterol. Another one is abnormal clotting. So the box, if you like, is premature cardiovascular risk. So type 2 diabetes particularly is really about your heart attack risk. The sugar is just one component of lots of different things that you need to address. So the whole box is associated with that premature risk of heart disease through early atherosclerosis, combined with some genetics as well.
Can I ask one more question? Sorry. People with nephropathies, how realistic is it that they will get transplants?
It depends whether you're watching the Hammersmith programme or not last night. So, I mean, I think in diabetes, sometimes, particularly the type 1s who need a kidney, they often now have it combined with a pancreas transplant as well. So sometimes they get that as a double transplant. But I think diabetic patients are not thought of as being less or worse, more advantageous than the rest of the population in terms of waiting time. So I think normally it's within a few years, depending on sort of priority. There's a lot of live donors now giving kidneys to their relatives, etc. And you can go to China, Pakistan and other places and get a kidney quite happily as well these days. So I think to some extent the donor population is getting bigger than it was historically because so many more people are being assessed and donating kidneys.
Thank you very much. Okay. Thank you. Well, our third and final speaker is our very own Richard Baker. I've got his printout here. It says he's an accomplished and very skilled advocate who shows great tenacity, determined and dogged in his approach. So it's like a terrier with a bone.
Yes.
Right, okay. And also, I think all of you that have a pen really have to draw the beard in.
Yes. Well, thank you for taking away my first joke there, Polly. Well, I think the legal slot is really becoming the depressing slot these days, isn't it? 2016 was a horrible year for a number of reasons, not least we're still seeing a large number of claimants' cases failing at trial. We've got fixed costs looming on the horizon, as we all heard last week. So I'm here to give you a bit of good news, and I'm here to talk about a case called Manor, which I did with Derek Sweeting, first instance in 2015, and then in the Court of Appeal at the end of last year. And just because obviously nothing good could happen in 2016, the judgment was delivered in 2017, at the beginning of this year. So in outline, this is what it's about. It's about providing adapted accommodation for separated families. So in the case where mum and dad have separated and you have a disabled child, what do you do? There's a touching upon, but probably nothing more, of Roberts and Johnson, which is a helpful sign of what might come in the future. There's a bit about pre-trial negotiations and costs, and there's a lovely bit at the end about indemnity costs and conduct. Okay, so here are the facts. Lemerio Manor was a young man involved. He was born on the 20th of December 1996. Known to everybody throughout the trial, including defendant's counsel as Lammy, which, considering what defendant's counsel was saying about him and his parents, I thought was a little bit friendly. He's a son of Sam Mather and Martha Cocking, who have separated, as you see, and he was injured at birth due to hypoxia and/or infection. And we compromised liability. Simeon was on the liability portion of the case. We didn't get rid of Simeon for a reason. I just want to make that clear. He was unavailable for the quantum side, which is why Derek stepped in. Compromised on a 50% basis in June 2014. And there you can see what Lemerio's problems were. He has bilateral tetraparetic cerebral palsy, severe learning difficulties, challenging behavior problems. He had an overlayer of autism as well. Unpredictable violent outbursts, which were a significant feature of this case. And the family history was Sam Manor, who was a father, is 68 years old, or is about 68 years old. Martha Cocking, his ex-wife, is 38 years old. They were married, and the relationship ended in 1998, a couple of years after Lemerio was born, and they subsequently divorced. And Sam Manor, happily bucking the trends for many fathers, was a primary carer until 2001. And that's quite a significant feature that we have to bear in mind. Mrs. Cocking remarried in 1999. She started her own family, and because she was starting her own family, Sam cared for Lemerio because Mrs. Cocking had a difficult time with her first children. So Sam stepped in and took over really primary care of Lemerio until 2001. And then Lemerio went to live with Mr. and Mrs. Cocking in Bolton, as you can see. And Sam Manor continued to live in Moss Side. And they had shared care, i.e. Lemerio would go and stay with Sam 3 weekends out of 4. Sam didn't drive. Moss Side to Bolton is a distance of 16 miles. And what Sam would do is he would get on the bus and he would travel into Manchester, and he'd get another bus out from Manchester to Bolton, and he would pick Lemerio up, and he would get a bus back with Lemerio and then into Manchester and then to Moss Side. And it took him an hour and a half each way, 3-hour round trip. And yet he still did it 3 weekends out of 4. And he did what he could to adapt his property. He had a local authority flat, and he made some adaptations to it. But in 2013, remember by this time Sam is getting on a bit, there are difficulties because Lemerio has got older. Sam is getting on a bit. There are some difficulties with Sam caring for Lemerio on his own in the house in Moss Side. And there were some issues that he would have to pop out from time to time and leave Lemerio on his own. And Mrs. Cocking was unhappy about that, not unsurprisingly. But it was a view of both parents, both Sam and Martha, that they would like contact to resume on an overnight basis. And Sam, of course, was carrying on visiting Bolton, and he would take Lemerio out to McDonald's and things. And it was subject to Sam receiving adequate support. Forgive me for going through the background because it's quite important, though, as you'll see in a minute. Now, it was accepted, and it was common ground between the parties, that Sam's house was inadequate for Lemerio, and the costs of what it would cost to buy a new house, or buy Sam a house, and adapt it, were also not an issue. But how do you deal with a situation where you're buying and adapting a property, the main residence for Lemerio, but you're also asking to buy a second property so that Lemerio can go and stay with his dad at weekends? You would think it's something that's been dealt with before. Trust me, it hasn't, because I spent a long time trying to find an example. And the only thing that comes close is Witten, which, if anybody's read it, is an enormous great judgment by Mrs. Justice Swift dealing with a cerebral palsy case and hundreds of little issues that would arise in one. In that case, there was an application. First, there was a claim for a second property in France, so that the claimant could go and live or have holidays in France, and that was rejected. But what Mrs. Justice Swift did do was she permitted adaptation costs of a grandparent's home in Barbados, so it was acceptable for the claimant in Witten to go and stay there. Now the case came on in 2015 before Mrs. Justice Cox, and she said the point is also made that if divorced parents living apart sharing the care of a child then had to cope with a serious negligently inflicted injury to that child, necessitating adaptation of their properties or the purchase of properties to be adapted, it seems inconceivable that a child would not be able to claim for the necessary adaptation or proper purchase of a new home for each parent. And that makes perfect sense, doesn't it? Because if you had parents who already had a shared care arrangement with dad, for example, having the child for a week, followed by mum having the child for a week, if that was the arrangement before the injury was sustained, then no one would see anything odd at all about the court giving effect to that by providing adaptations to both of their homes. And that would be a perfectly natural thing. But again, in the case of Manor, this took on the position of being something that was wholly unreasonable. It was something that was not only unnecessary, it was an exaggeration, that we were asking for something that really wasn't necessary. I mean, one particularly nasty point in Manor, and I'll come on to it now because I want to get it off my chest, is the argument made by the defendants that Lemerio was so disabled that it didn't really matter if he didn't see his dad because he wouldn't remember. And so there was no benefit to him seeing his dad. And so really, did it matter? You know. Now they ran an interesting second horse argument, of course, because you remember at the start I said that Lemerio had problems with behaviour and an overlay of autism. Well, they said, well, no, the behaviour problems, they're not caused by his brain injury. They're caused because he's separated from his dad and he's really upset. And once we restore contact with dad, not by giving a second home, just by restoring contact with dad, he'll get much better. So they ran those two horses, slightly contradictory, you might think, but they went with it at trial. Now, what was said by Mrs. Justice Cox, who you would imagine I have a lot of time for given what she said about our case, given these factors, the long history of shared care in this case, Mr. Manor's extensive involvement in his son's life over many years, a relatively modest cost, it was several £100,000, so the defendants became quite upset about the reference to modest. But and my conclusion that it is very much in Lemerio's best interests for his relationship with his natural father to be restored. I am persuaded that this claimant is entitled to the costs of a second property. And I emphasise that the decision has been reached on the particular evidence before the court in this case and is not to be regarded as establishing any wider precedent. Well, I mean, we'll see. So we come on to the Court of Appeal because the defendant was very upset about a number of things in this case, one of them being the second home. And they ran for a long time throughout the case in saying, well, our main argument is going to be it's an unnecessary extravagance to have a second home, and Lemerio doesn't really care anyway because he's so disabled. They decided from that, but at the last minute they changed their arguments to be a little bit more nuanced. And so what was said by Tomlinson, Lord Justice Tomlinson, he said, well, it's a novel point, isn't it? There isn't any authority dealing with this at all anywhere. And he said it's quite surprising that because divorce and separation must be a common feature in cases where there's a child with severe disability. And it's curious, isn't it, that it's never arisen in any other cases. Now, it's not that curious because how many cerebral palsy quantum cases actually go to trial? Not many. Most are settled. So it's not that curious, but he considered it to be curious. And he said, Witten, it's not really authority to say that there's a second property can be bought because all it was £7,000 or £8,000 to adapt a property in Barbados, which was cheaper on balance than claiming for costs of extra holidays or accommodation and things like that. So it was a pragmatic solution, but it's not an authority. And he said it's a generous award, the second property. But then he goes on to say, and again, anybody who saw a talk I did on psychiatric injury claims a couple of years ago, I was quite unfair, I think. Well, not fair. I was quite nasty about Mr. Lord Justice Tomlinson and what he'd said in Ronayne. But I've warmed towards him now. And generosity towards a claimant as disadvantaged as is Limerio may not be misplaced. And I agree with the judge that her decision in this regard should not be regarded as establishing a precedent. The claimant was entitled to spend time with his natural father after his parents' divorce, and these are very least reasonable expectations to which the law should strive to give effect. And of course, it's natural, isn't it? Because why should the disabled child have any less rights than the able-bodied child who would, according to the Children's Act, be given the facility to spend time and live with both of their natural parents? So why should there be a difference? And what were the factors, the important factors in this case? I mean, there's a long history of shared care. Dad was the litigation friend. Dad had been the sole carer for the first 5 years of Limerio's life. And Dad had gone out and seen Limerio and had Limerio staying over 3 weekends out of 4, and had continued to go and see Limerio at his ex-wife's house, even after overnight contact had been withdrawn. So he was a person who was committed to Limerio and who was quite happy to make the effort and go out and see his son. And he'd made adaptations to his own home to accommodate his son. The shared care arrangement had broken down, but that didn't mean it couldn't be restored. And it was the agreement of both of the parents, natural parents, and indeed the stepfather, that the previous care arrangement should be restored, and that was an important factor. And it was in Limerio's best interests for his relationship with his natural father to be restored and to allow contact at his father's home. So how does this help in terms of precedent? Because both Lord Justice Tomlinson and Mrs. Justice Cox said this isn't intended to set precedent, but it's hard for it not to, isn't it? Because once it's been allowed in one case, doesn't it become something that's arguable in other cases? And shouldn't there be a benchmark as to how we judge whether it's appropriate in one case or appropriate in another? Now, the difficulty of having an alternative arrangement was an important factor in this case. There wasn't a comfortable, easy middle ground. Mr. Manor was having to get the bus to and from Bolton. It was not considered ideal for him to be spending time seeing his son in the home of his ex-wife, because that's to him not a natural environment, and nor was it appropriate for his contact to be limited to taking Limerio out into the park or to McDonald's or whatever. Now, shared care arrangements are common. My view is that the homes of both parents in those situations should be suitable to enable the child to have a proper contact arrangement with both of their natural parents. And again, the history of commitment, the history of there being a shared care arrangement in the past, I think is very important. It was raised in argument, but not really in the judgment, that one of the factors in this case, maybe if there was a dispute as to a shared care arrangement, should it be the job of the lawyers to have that sorted out in the family courts before we come on to the issue of quantification of damages? And it was suggested that if the parents weren't agreeable to a shared care arrangement, then it would be necessary to sort that out in the family courts before quantifying the case. But again, past contact and commitment are plainly highly relevant. Now, that was the main argument. There were two elements to this second accommodation claim. The first was the defendant said, well, it's not necessary. The second is the defendant said, well, claimant, you've pleaded the Robertson Johnson calculation by reference to Limerio's life expectancy and not his dad's. Now, this became quite a significant issue in the case, but unfortunately it didn't become a significant issue in the case until after the trial, because the defendant never argued it at the trial. The counter-schedule disputed the entitlement to a second property, but did not raise issues with our multipliers. And the defendant didn't argue it until after the draft judgment had been provided for parties. And what happened was, Mrs. Justice Cox emailed the judgment out, and we saw we'd won, and we all were very excited. And then an email came from defendant's counsel saying, no, you've put the wrong multiplier in. And we said, oh no, you haven't. You've put the one in we asked you to. And then they said, oh no, hang on a minute, it's plainly wrong, isn't it? And we said, well, I'm sorry, it's been decided. This is Lord Justice Tomlinson again. In seeking permission to appeal on this point, Mr. Seabrook sought to justify not having raised the point at trial by pointing out that the defendant had perhaps focused on simply defeating the claim, which he regarded as lacking merit and unlikely to succeed. The judge regarded this as a tactical assessment. Whether the course adopted was deliberate or the product of oversight, it is optimistic on the part of professional litigators represented by specialist solicitors and extremely senior counsel, vastly experienced in the field, to revisit a critical aspect of the calculation which they had not challenged at trial. I don't know whether it was oversight or a tactical decision, but the point was they very aggressively took the view that the second property was an extravagance and wouldn't countenance any negotiation at all on the basis that we were entitled to the second property. Their negotiating position at the JSM, whenever, was you are not having the second property and we will not negotiate on any basis that involves it. So there you go. So their position was to try and argue the point about multipliers in the Court of Appeal, having not argued it at first instance. Now let's come back to Robertson Johnson, because the issue with Robertson Johnson is this. You are not giving, you're trying to do justice to both parties. You don't want to give a windfall to the claimant's estate by providing with an appreciating asset. So what you want to do is you want to try and modify the calculation, so by awarding a percentage of the total amount per annum. And it's said by Stocker LJ, the object of a calculation is to avoid leaving in the hands of a plaintiff's estate a capital asset not eroded by the passage of time. Damages in such cases are notionally intended to be such as will exhaust a fund contemporaneously with the termination of a plaintiff's life expectancy. Now, I had to read Robertson Johnson again in relation to the appeal, and it's quite an interesting read, because having seen Robertson Johnson referred to everywhere for years, you expect this sort of gilded authority with lots and lots of things about accommodation in it, and it isn't. It's an authority that deals with lots and lots of other things and comes on to the question of accommodation over the course of a couple of pages right at the end. And one of the things to remember is 1988 case, the cost of purchasing what was regarded as an expensive property at the time was £86,500, as against the value of a claimant's home, which was £18,000. And you have adaptations of £38,284. And the total claim, including adaptations and accommodation, was £88,000 or thereabouts. And general damages were £78,000. So you may say, well, okay, we're doing it on a different basis. We're only awarding you a proportion of a total cost of accommodation, but it's not a major problem for the claimant, is it? Because the claimant can practically buy the house and do the adaptations out of general damages. And we've got these problems, haven't we? Property price inflation, the relatively modest inflation of general damages awards, the impact of the discount rate, and the impact in cases involving short life expectancy, none of which are dealt with at all in Robertson Johnson. Now, it's really the first two that in lots of cases cause huge problems, because you have property price inflation, you have vast amounts needed to buy and adapt property, whereas general damages, the awards of general damages have hardly changed in the last 20 odd years. And so in the past, where you could have said, well, look, I'll pay for the accommodation or the difference in accommodation out of the general damages, you can't. So what you're having to do is you're having to utilize parts of the claim that are used for things like care or equipment or other things that are necessary and what you need to buy. You're having to use those to buy the property. And that causes an injustice. But also, what do you do in the cases involving a short life expectancy, where the multiplier approach doesn't help? Because rather than being able to multiply the annual sum divided by 2.5%, rather than being able to multiply that by 30, you're only able to multiply it by 7 or 8. And you'll be left with a situation where you just can't afford to buy the house. And and Lord Justice Tomlinson, and to be fair to Lord Justice Tomlinson, given his previous statement, most of this is obiter because obviously the defendant hadn't argued it. And he says awards of damages in cases of this field must be at a level which neither results in an injustice to the defendant nor is out of accord with what society as a whole would perceive as being reasonable. It's a Highland ranking statement there. Now this is salutary, but society as a whole would not perhaps understand that an award elaborately structured in a manner which will ostensibly permit the attainment of a number of objectives desirable in the interests of the disabled child might not in fact succeed in enabling the claimant even to acquire the accommodation deemed appropriate for his care. So in simple terms, what Lord Justice Tomlinson is saying is, well, if we're thinking about how society would perceive awards of damages, wouldn't society seem to think it a bit odd that you're claiming for accommodation, but actually you can't buy accommodation? The defendant contended that the second home should be calculated according to father's life multiplier. Now remember, father is 68 years old, and the effect of that, obviously plus the 50% discount for liability and litigation, which of course we can't take into account, but the effect of the short life expectancy meant that there would be an inadequate sum in any event to purchase the property. And what we had done is we'd adopted the claimant's life multiplier as a pragmatic solution to provide us with enough money to buy the accommodation. And what Lord Justice Tomlinson said, he said, well, Robertson Johnson, okay, it's imperfect, but it's pragmatic. The way that Derek Sweeting put it very eloquently in the Court of Appeal was it was imperfect perfection. It's not the ideal solution, but there's no authority for adopting an alternative multiplier. Now that's quite important, because if we did start adopting alternative multipliers to the claimant's life expectancy, then we could end up in a bizarre situation. Because in the case of most claims, cerebral palsy type claims, you have a large property which is designed to provide accommodation not only for the child or young adult, but also their parents and carers. Now, if you were to start using different multipliers from the claimant's life expectancy, then the defendants might argue that actually you don't need a big property for your entire life. You only need that property for your parents' lives. And then when they die, you can have a smaller one. So we don't have split multipliers in Robertson Johnson. We just have the claimant's multiplier. It's the traditional approach. The Court of Appeal said, well, there's no authority for adopting an alternative multiplier, despite the fact that the claimant's accommodation needs will change over the course of their lifetime. And they said if a point had been raised at first instance, the claimant would have argued for alternative structures, and we would have done such. We'd have said, well, okay, we can't buy a house because of Dad's life multiplier, but how about you provide us with the costs of renting an appropriate accommodation with a premium against us being allowed to adapt it, and also the cost of adaptation. And at least that's a pragmatic solution, and it terminates, the need for it terminates when father dies. Or you have a reversionary trust. You say, okay, you buy the house and you can have it back, plus any increase in value. And that provides the accommodation, but it does away with the mischief of Robertson Johnson, which is that you leave a windfall in the estate's hands. But we weren't able to argue any of those because we'd argued it on traditional approaches. The issue had never been raised at trial. And what the defendant was trying to do was to say, no, you've got to have the worst option. And that's, you've got to have the option which means you get Dad's multiplier. And of course, when we said, well, if it had to go back, it'd make quite a difficult second trial, and none of us find that particularly attractive. You know, what is the option? The option really is to stay with what we had before. And this is what Lord Justice Tomlinson said. The defendant's challenge to this point is an afterthought, and it's now too late to be permitted to suggest that whilst the Robertson Johnson model is not appropriate to this head of claim, it should be adopted only with the use of a multiplier other than be appropriate for the claimant. And that would throw open the debate the entire wider inquiry on the basis of what, if any, financial model the claimant claim for a second home should in this case be permitted to succeed. The outcome of such an inquiry might of course be recovery on a different and more generous scale, conceivably however it might not. Now, That has to be an obiter comment, really, because any criticism of Roberts and Johnson has to be obiter, because what was being said is, I'm sorry it wasn't argued at trial, it's too late to raise it now. But it's actually the first recognition in authority that there are alternatives. There is a case where an alternative structure is approved by the court, but there's very little said about it and the justifications for it. There's been a lot of academic discussion about the problems with Roberts and Johnson, in particular on short life expectancies. But this is the first authority that actually really addresses those problems head on and says, look, there might be alternatives. Now, the purpose of the approach to accommodation, of course, has to be to ensure a fair solution to both parties. And Roberts and Johnson remains pragmatic and imperfect, but it will apply in most cases. An alternative structure should, of course, now be considered, as they probably already have been, in cases where there is a short life expectancy. Now, indemnity costs, this is a bit that we all got very excited about. Now, Laura Cox awarded indemnity costs on the basis that the defendant had failed to enter into meaningful negotiations and collaborative negotiations, which they had. They'd just told us to F off, basically. The defendant alleged that Mr. and Mrs. Cocking were dishonest and exaggerated the claim, which was unsustainable and inappropriate in the context of the claim. So I mean, it's a particularly nasty case on a number of levels. And one of the particularly nasty features, and I had to sit through the cross-examination of Mrs. Cocking, was it was put to her, for example, that her son probably wasn't as doubly incontinent as it had been suggested, because when the care expert went round to the house, there wasn't poo everywhere. And she said, well, it's because I sort of scrubbed the place with bleach before the care expert came round. And they said things like, well, you've got this Land Rover Discovery vehicle instead of the usual VW Caravelle, and I bet you like driving around in that flash car, don't you? And she said, well, not really. I get quite upset about it, because every time I see this car, I think the only reason I've got this car is because my son is disabled. And she didn't put it quite as directly as that, because she spent a lot of time crying in the witness box, as you'd imagine. So there was lots and lots of nasty cross-examination that were suggesting they were exaggerating and that they were lying and that they were greedy and basically had ideas above their station. And it was pretty unpleasant to sit through. So when we won and the court said that that was all particularly unpleasant, what we did was we asked for indemnity costs because of that. And we also threw in that they'd not entered into collaborative negotiations. Now, the collaborative negotiations part didn't succeed. What the Court of Appeal said, I think quite rightly, is that you have Part 36, which has an indemnity cost provision attached to it. If you want indemnity costs, use Part 36. You know, the court isn't going to get embroiled in a question of whether somebody was meaner to JSM or whether somebody should have made a better offer. That's it. You know, use Part 36 or don't use Part 36. And that's essentially the approach. So we were getting a little bit worried at this point that the indemnity cost bit might not hold water. But fortunately, it was found that the defendant's conduct at trial, in fact, the defendant's conduct at trial was elevated because you'd taken away the collaborative negotiations bit. So the conduct at trial became elevated to something that really was worthy of sanction. And they were alleging at trial that Mr. and Mrs. Cocking were dishonest and greedy. And also they had expert evidence that was illogical and unrealistic and wholly unrealistic, and her allowance was extraordinary and wholly out of kilter with the awards made in this area. And the OT provision by the defendant for Lemerio was two things. It was a sensory blanket and a special ball that he'd be allowed to have. And that was his OT provision in its entirety. No replacements, just one of each for the rest of his life. And Derek, I wouldn't have been as calm about it, but Derek heard that come from the OT and he said, it's going to look a bit weary, isn't it, after a few years? And it's right, of course, it's just one of each. And it was wholly unrealistic. It was a cerebral palsy case. Lemerio needed assistive technology. He needed sensory equipment. He needed all sorts of AT and OT equipment to make his life better. And Lord Justice Tomlinson said, I've no doubt that the judge acceded to, I've no doubt that had the judge acceded to the defendant's suggestion that the claimant's case was deliberately exaggerated, the defendant would have sought an award for indemnity costs. Of course they would. If they found that Mr. and Mrs. Cocking had exaggerated the claim, there would have been an application at the end to disallow some of our costs or have indemnity costs against us. And what is sauce for the goose should be sauce for the gander. Looked at him around, the judge who heard the trial, and who I might add had heard many like it, plainly concluded that what had occurred fell outside the norm. So the discussion is the only effective way to obtain sanction in relation to pre-trial negotiations is by making Part 36 offers, but conduct at trial can be a relevant consideration in relation to indemnity costs. Thank you. Any questions?
I'd like you to play devil's advocate to your own case, if I could, because in a case which I did recently with Simeon, we had an argument at Eels situation that we should rent for the rest of our life,
Yes.
even though the parents are together. Is not the logic of the way PPOs are developing to, in that situation, look to rental, particularly where you've got an apportionment of liability, so you're never going to get the full amount, to look to rental on the basis that you'll have an annual figure for however long the child lives, and it gives that element of security and covers for how long the father will live?
There are two issues with rental. So what was said in submissions to the Court of Appeal in Manor was that actually we can't afford the house anyway because we're only getting 50%, but we will use the sum of money obtained through the Roberts and Johnson calculation to rent property. But you can't take that into account because you've got to judge it on a 100% basis. So rental is often the pragmatic solution anyway. The difficulty with rental is that you have to pay a landlord's premium if you're going to adapt the property. And it's quite difficult to get property that landlords are happy for you to knock about in the way that's necessary in most CP cases. And also the availability on the rental market of those sorts of properties as well. But I agree, it's often a pragmatic solution to deal with, especially in short life expectancy cases.
It just seems that defendants in all of these cases are looking for this solution, even where the parents aren't separated, particularly with London property, where the prices are eye-watering.
Oh yes, I mean certainly in relation to London properties. I mean there are difficulties with lots of solutions here because for a reversionary trust solution, the difficulty with that, of course, is you have a family live in the house together, and then when the child dies, they have to give the house back with all the memories that are associated with it, which is quite a horrible sort of notion for some people. But it's a difficulty. If the alternative is you have to do it on a Roberts and Johnson with a short life expectancy, and you can't buy the house, you know, there are always going to have to be compromises made. And I think renting is certainly in London with London property is usually the most sensible way in a short life expectancy case. And presumably attached to a PP as well. That was.
And just to round it off, because I've forgotten, how long was Lammy's life expectancy?
Lammy had a, well, it's only longer than his dad's. His multiplier was about 27, I think.
Right.
Yeah.
Thank you very much.
Right. The most important part of my job is to tell you, please fill in the form. Oh, is there another question?
No, well, just a comment really about the conduct at trial and the exaggeration. Presumably, it wasn't sufficient simply that the allegation of exaggeration had failed.
Yes.
The judge was saying that in fact it should never have been put at all, and was therefore unsupported by evidence.
Yes. Yeah. I mean that's it. And I mean what was said, of course, is that trials are difficult things. And difficult things have to be put in trials. And so the argument from defendant was, well, of course we should be allowed to have a freedom to engage in a trial how we see fit and not be fettered by the idea that we might subsequently be fined out and punished with indemnity costs. But it was said in this case it had gone well beyond it's normal rough and tumble.
It's the old-fashioned common law principle that you don't put something to somebody unless you have evidence to support it.
Yes,
and that gets forgotten sometimes in civil litigation.
Certainly it was elevated to dishonesty in this case as well.
Okay, now I can say it. Fill the form in, please. That's what informs makes this ongoing. But thank you very much to our three speakers, to Richard and to Mark and to Michael. Thank you all very much. Thank you.